This is really what I'm supposed to be talking about, which is our ALS clinic. And so we have a wonderful multidisciplinary clinic that if you look into the literature about ALS, people that attend these clinics have a longer survival and a better quality of life, mainly because of that. Would everybody that is here, not all our team members here, but would all the team members that are here, would they please stand up? So that we can, I just want to just show the team members that are here. David Burkett, our social worker, Mary Jane Youngster, who's our occupational therapist, Maureen Walsh, our research coordinator, and Anita Hill, our ALS clinic coordinator, Laura Herbelin, who also is highly involved with research and education, and in times past actually used to pay for the ALS lunches. So she's like an honorary member indefinitely for the ALS clinic. Okay. So the different members here, we have 2 neurologists that are always attending at this clinic, Dr. Barohn, our chairman, and myself. Occasionally we will have another rotating physician come in to cover Dr. Demotchke, Dr. Wong. Dr. Wong also attends the MDA clinic. Anita schedules appointments and answers phone calls, answers questions, tries to get paperwork transmitted back and forth to who needs them. We have, fortunately, and then can I have Nancy stand up as well? Nancy is our ALSA nurse. She used to have a partner, Linnea, who for so many years worked so hard for the clinic and is retired, but now has been replaced by Julie Williams. So we have another helper in there that they frequently, one or the other of them will be at the clinic to help us coordinate and facilitate things. That Nancy and Julie can go right into the home, and everybody knows how accessible they are. So that really is, she's definitely one of the essential team members here. David Burkett is our social worker. He has several functions. He is there to address issues such as transitional concerns, going from working to not working. He is there to address advanced directives for those people that need help in getting those done, to get access to expensive medications such as Riliatech through the National Organization of Rare Diseases. He is there to help facilitate the transition into hospice, nursing home care, and also to counsel for depression and anxiety. And so he has several functions on our team. The occupational therapist, Mary Jane, Mary Jane's very, very experienced and has been in our clinic pretty much the whole time that we've had this clinic. She addresses occupational therapy issues with the upper extremities, but she does more than that. She actually does a lot more than that. That's just a simple explanation of what she does. Lindsay Heydrich is a new member of our team. She's our speech-language pathologist. I'm going to show you a little slide of what she does. She and also some assistive communication device technicians work with her and sometimes attend the clinic, but she does all these different things, including cognitive screening for dementia in people that we believe may have frontotemporal dementia, and also goes through and shows what PEG tube equipment is like when people need to know more about, well, what is this procedure about the PEG tube? What exactly does that consist of? Finally, we get down to Mike Cervinsky, who is our respiratory therapist. He helps us not only with monitoring what the respiratory strength is on our patients every 3 months, but also helps us as far as getting the correct type of equipment, such as BiPAP, and also works with the apnea people who attend our clinic to get that taken care of while you're in the clinic. So that's very nice that you can actually have somebody there get you started on that equipment when you need to. BiPAP prolongs survival. BiPAP improves quality of life. So the timing of that is important. That's why you get tested on that every time you come in. Our dietitian is important. A lot of our patients are losing weight or have questions about nutrition. And then we have other helpers. But Maureen is our research coordinator. Some patients come from several states away just to participate in our research studies. We have people from Iowa and Arkansas. We have people from all over. Even though we actually only cover, because of our affiliation with the Keith Worthington chapter, we cover 3 states, but we sometimes get people coming from even beyond those 3 states. And then what can we do? People can say, well, you have this diagnosis. What can you do for us besides the research, besides these other interventions? And people are always, these are very common symptoms that patients develop at some point during the course of disease. Not everybody, but some. And these are things that there are interventions and treatments for, so we want to know about these symptoms and address them. There's equipment needs, and our equipment specialists, as well as our physical therapists and occupational therapists and speech therapists, those people will also go through their checklist to make sure you have the appropriate equipment at the appropriate time. And then other interventions, PEG tube intervention, and BiPAP. Those are things that you come to the clinic so that we can know when the proper time is to intervene on those as well. The very last thing I want to say is that something that's very unique to our ALSA chapter, to the Keith Worthington chapter, and something that was started by the, actually, was it Sally, was it you or Becky, you and Becky started this, where basically you became very interested in telemedicine. And what we did have initially a grant that funded the telemedicine program, and now we no longer have the grant, but still in cases of people that are well established with a diagnosis, once we've seen them at least once or twice and they had a definite diagnosis, if those people can't make the trip from outlying regions from hours and hours away, this is something that at least for me, I can at least, the visit for me and the patient and the local coordinator, we can get together and try to address concerns because there are people that find it too difficult to make the trip. Look at this picture of Kansas. We have telemedicine sites at the yellow pictures, and then there's actually, this was done maybe 3 or 4 years ago. These are where they located various patients with ALS. And so, yeah.
Are there certain sites that they have to go to?
Yeah, they do. They have to go. We do Pittsburgh, we do, and then, yeah, so where's our other little site that we do? I've actually, if I look at the pictures that we've done Hayes, we've done Pittsburgh, I don't know if we've done Garden City, and Wichita, yeah, and Wichita as well. So there's several sites that if people can go there closer, then we can at least talk to them. Because it's interesting to me is in taking care of ALS patients, a lot of times, yes, we want the vital signs, yes, we want to have the forced vital capacity and the breathing test numbers. But once I have that, a lot of it's just simply talking to the patient about what's going on with you. There's a lot of communication and care that we do either by email or can be done even through telemedicine. So for those patients that can't make it, at least that's something that's unique to this particular ALSA center. Anyway, I'm going to pass on now. Dr. Barohn is going to be talking about the research studies.
Dr. Dick, do you want to say anything at all about the two things that's very similar in sorts of group of patients?
Yeah, it is very similar.
Groups of therapists.
We have a team very, very similar to what Dr. McVey just outlined. And we sometimes see patients in our clinic who have been seen in ALSA and vice versa. I think we are sister clinics, and I think between us we serve the population of ALS patients very well.
Thanks, Dr. Dick. So, Dr. McVey, I said we see 2 to 4 new ALS patients a week. Is that about right?
I'm just going to add, my voice is actually pretty loud, but I'm going to use this microphone. What's interesting is that our clinic population continues to grow. We have noticed that we have an ever-growing population of patients. We see follow-up clinics every Monday morning. We have follow-ups, and it could be anywhere from 8 to 12. We're trying to keep that more to 10. We have a new patient clinic where I see new ALS patients on Wednesday afternoons and, if necessary, Friday afternoons. Last year, we saw 400 patients with ALS.
Yeah. So it's one of the busier clinics in the U.S. So I'm going to just say a few words about research. Actually, I will say something else. One of my titles as chair of the Department of Neurology is I'm the Gertrude and Dewey Zeigler Professor of Neurology, which I'm very proud of. Dr. Zeigler was the first chairman of the Department of Neurology. He's still alive. He's 95 years old. He's still in the department. He comes to his office, and he does whatever he wants. We let Dewey do whatever he wants. He's great and is just a very wise person, very smart neurologist and physician. So I'm very proud to be the Gertrude and Dewey Zeigler Professor of Neurology as chair. So to summarize things, there's one drug that has shown to be effective to slow down ALS, and that has FDA approval. That's Rilutek. I'll talk about that in a slide in just a minute. Just one. We have probably, since Dr. McVey and Dr. Dick and I have been doing this, have probably been involved in 3 or 4 dozen phase 2 and 3 trials that have not gone on to find an effective drug. And at any time, we'll have 5 or 6 active trials going on. Sometimes it's down to 1 or 2 if we're between studies. So it's busy. We keep looking, we keep trying, but obviously there's only been one that has shown to slow it down, for sure. So this is what the terminology that is used in drug trials, all drug trials, not just ALS, and to keep this in mind. So the stuff that Dr. Swerdlow works on in an animal lab or cell culture lab is preclinical. That's to find a compound, and then the first step into humans is phase 1. And we are just starting to do phase 1 trials here at KU. We've been in a couple ALS phase 1 trials now, and one of them's going on to phase 2, which I'll mention in a slide coming up. So phase 1 is where you just give a handful of patients, 10, 20 patients, the drug, make sure it doesn't do anything bad, and you're not trying to find out if it works. Phase 2 and 3 is starting to get to does the drug work for the disease. And the phase 2 studies tend to be a bit bigger, but usually less than 100. And then in order for a drug then to actually get approved by the FDA, it's got to go through a phase 3 pivotal efficacy trial. Most diseases have to have 2 phase 3 trials, but because ALS is a rare orphan disease, the FDA, if we get lucky enough to get a drug, which we will, it can usually get approved with 1 phase 3 trial. And then the drug's out there and we're prescribing it in the clinic, and then studies done to see how those patients are doing on the approved drug are called phase 4. So this is the terminology that's done, and Dr. Weir is going to talk quite a bit. Dr. Swerdlow is involved a lot of times in the preclinical. Dr. Weir is involved in both the preclinical and the phase 1 stuff, and then Dr. McVey and I get more involved in phase 2 and 3. So there's a whole succession of scientists that get involved in these sort of things.